here is actually continuing into the esophagus.
Okay, this vessel is continuing into the esophagus.
This is the paraesophageal. We can already see we are going into the esophagus now. So this patient also has esophageal varices, I believe.
Okay.
This patient also has large esophageal varices. We can see those here. Right here we can see the GE junction.
Yes.
We can see the GE junction.
Because this is the muscle layer for the GE junction. These are the paraesophageal.
These are the paraesophageal.
This we don't want.
This we don't want.
We are more interested in the vessels which are going down from the hilum of liver.
Yes. Right here.
Right. Which are going into this. Which are going into this area.
Yes. So we know that this is. So can we switch on the color Doppler, please?
Yeah.
Dr. Sahaj?
Yes.
Dr. Varun here.
Yes, please. Yes, sir.
How do you decide which patients to be taken for BRTO or which patient to be taken up for a coil without having done a CT?
So, sir, that's a good question. For example, here in this case, this is a patient who has come with a bleed. So, I mean, this would be a fair case for an EUS guided obliteration. If I have an elective case, then the question does come up, and the general teaching in general is that if it is too large, you go for BRTO, and if it is not too large, let's say 3 centimeters or smaller, then you go for EUS guided. However, that said, in our center, in most of our cases, we go for EUS guided gastric varices. We have gone up to 7.5 centimeter varix using EUS only.
I think this is too early to say that too large BRTO. There is no official.
There is no official. This is still a very nascent space. Can we have the normal color Doppler, please, sir? Not the high flow one.
This one.
See here.
Color.
Right. Yeah. So here now this is important. Can I? So we will reduce. So here this is a very heterogeneous looking color Doppler. We want to optimize this. Now these feeders, these vessels usually have a speed of 20 to 30 centimeters per second. To identify which is the feeder, we want to get rid of the aliasing. We want a pure white and pure red and blue signal. We want a good signal to identify the direction.
I decrease the velocity to 2.
No, we want to increase the velocity.
Too many color. Too many color. I will increase the velocity slowly.
Yes, sir.
Now 12, 16. Now this is 16 more.
More. We could go up to 25. Something around 25.
25.
Yes.
Now
Perfect.
this is 25.
So now we have pure reds and blues. Now we know what is coming towards and what is going away. I am going to zoom to an appropriate level. Now I know that whatever is flowing towards my transducer is the red, and whatever is flowing away from my transducer is blue. So now let us look at the varix. So this is where's the right here.
This place is this is the place which is inflowing.
No, I don't think, sir. I don't think that is the inflowing. I think that is probably the outflowing.
Okay.
Here is, so we know that the varix is being fed from here because this area is red. So this is coming towards the varix.
Okay.
This flow is coming towards it. So I would want to trace this further. Sometimes if we have a pre-procedure CT, then that makes life easier, but we can do it on table also. Let us see. So let us look at this spot, this area. Now this again is red. This is flowing towards the transducer. So this is most likely the feeder to the whole varix. Now we'll trace it further down. We'll trace this further down. Because we have increased the velocity range that much, we will see a lot of black spaces. We can readjust it, but maybe we can just leave it for that because we don't want the low flow. We want the high flowing areas to be clearly visualized. And we are going to trace it down, and here we can see that this is what the feeder is. We can see that this is where the feeder is coming from. And the best thing to make sure that we are dealing with the feeder is to trace it back to the portal vein. So we are going to try and trace it back to the portal vein. So we can see
in this
right
case,
here.
Splenic vein.
So when I say portal vein, I meant the splenoportal axis. You are correct.
Splenoportal axis,
so
yes.
So this looks like this is probably a posterior gastric vessel. Let me go back and trace it right here. So we have gone all the way back to the varix. We have identified the varix. If if we do not want to go through all the hassle of finding the feeder, it is perfectly fine to inject here. We can occlude this thing with probably a couple of coils and inject glue, and this will be done. However, if we want to go all the way and find the feeder, we can trace it back over here, find this going over here, we follow it, and here.
I think so.
Right
we,
here.
Straight away proceed now.
All right.
To proceeding coil.
All right.
Because
so,
we have to establish your theory